$100 million for mental health. It's part of the government's 2026 health budget, and we now have a breakdown of where it's going. Broadly, it's for new mums, new inpatient beds and new psychology assistants, plus a bit for groups working in communities. I'm Alexia Russell, and today on The Detail, we're going to go over Health Minister Matt Ducey's announcement and ask if the funding matches the need.
Limited access to mental health support and the lack of job opportunities are the two most pressing issues facing young New Zealanders today. That's according to the latest Youthline ASB State of the Generation report, which highlights the concerns of more than 1,000 12 to 24-year-olds. It reveals a generation grappling with rising living costs and constant societal pressure in an always-on digital world.
The parents of a 13-year-old who died by suspected suicide after contacting multiple helplines are pleading for better information sharing by crisis services.
Either spend money today on young people and an integrated, cohesive mental health system for young people today, tomorrow, in the next year, in the next election cycle, or we can spend 10 times that in a decade when these young people are adults and they need our adult services.
Dr Haram Fabru is the chair of Tuti Akakaroa, which is the New Zealand office of the Royal Australian and New Zealand College of Psychiatrists. I'm asking him what's good, what's missed out, and how far this funding goes towards solving the massive problem that is inadequate mental health services in this country.
We welcome any investment in mental health, particularly areas like maternal mental health and inpatient care, but we are concerned that the proposed solutions are unlikely to address current problems and possibly create new ones.
What was in the announcement, first of all, that you're happy about?
Well, I think the increase in kind of funding for inpatient beds is beneficial. We know there's been a shortage for quite a while now, and that people are being admitted they have to be really unwell before they can get inpatient treatment, and they're often discharged ahead of schedule to make space for the next person who needs a bed. So we know we've got a shortage of inpatient beds compared to demand.
But it's only 20 new inpatient beds, like 51.72 million. Is 20 enough? It seems like such a small drop in the bucket.
And that's part of the problem, is that it probably isn't enough to actually meet kind of current need. And also, more importantly, it's about whether, those beds actually translate into service delivery, because we know that we have a chronic shortage of psychiatrists and other frontline clinicians. So when we hear about new inpatient beds, our immediate question is, who's going to staff them? The beds alone don't treat people. It's the clinical teams around them that make the difference. And without those teams, there's a real risk that we expand capacity on paper without being able to fully operate it on the ground.
And does this announcement allow for extra roles? Because there is something that says new psychology assistant roles. Will those psychology assistants be hovering over those beds?
I don't believe the psychology assistants will be working in inpatient settings. From my understanding, they're meant to provide community-based care. And in terms of the new roles, such as assistant psychologists and peer support workers, again, it's great to have more workforce capacity. But these new roles can sort of help to diversify the workforce and task share, but they can't provide many of the services that highly trained clinical psychologists and other specialist mental health staff currently provide. And the problem with sort of well-meaning and top-down driven diversification of the workforce without clear role description and planning is that it leads to role confusion, conflict, and disenchantment amongst all groups. And it also leaves the public less certain about what they'll receive and from whom.
So what would you have liked to have seen in terms of new psychologists on the ground?
Well, I guess if I talk about the assistant psychologists, first of all, assistant psychologists will be trained to carry out a limited scope of work, so they'll be trained more quickly. They'll be able to deal with common mental health issues such as anxiety or depression, I understand, and that will help ease the burden for those issues, but it won't help to address the more complex or serious mental health issues such as bipolar disorder, eating disorders, psychosis, or OCD. We need more specialist staff trained in sort of treating these conditions, but also assistant psychologists will end up being trained in these roles and may not have anywhere to progress. We know we have a shortage of clinical psychologists. One of the things we've been calling for from the time this was mooted was the assistant psychology role should be a transition. There should be some bridging between those roles and clinical psychologists, so people can be trained to work in these and have further training to become clinical psychologists, because ultimately we know we need more of the latter. When it comes to peer workers, peer workers are incredibly important and they contribute greatly to clinical team functioning. But their roles should be complementary and not interchangeable with the specialist mental health workforce.
So what do you mean when you talk about peer workers?
People with lived experience, there's certainly a number of them in inpatient and community teams around the motto these days, and they're invaluable in terms of kind of, providing a lived experience perspective, providing kind of support to identify early and find out in a way that might be more acceptable, particularly for some of those who have historical or family-related reasons for being wary of traditional mental health systems and staff.
So these are people who've been through the system before, been through whatever these people are suffering from. They're there to support them and hold their hand, kind of thing.
That's right, yes. So they can offer kind of, immediate support. And I think when it comes to mental distress, they can be invaluable for helping to reduce that and reduce some of the burden that might otherwise fall on specialist mental health clinicians. But the problem with this kind of lived experience workforce, I guess it's interesting that firstly, there's this kind of artificial distinction between clinician and lived experience, as though many people working in mental health services don't have personal or finite experiences of mental health issues, which I don't think is helpful. And secondly, it's something that seems to be interestingly prioritized for mental health services. We're not talking about lived experience or peer workforce for physical health services, which is interesting and possibly perpetuates a belief that mental health issues are less serious in some way.
So there's $28.45 million for 150 new psychology assistant roles over 4 years. So will that go some way to ease the burden of clinical psychologists?
I would hope to a certain extent would ease the burden for people experiencing mental distress. I think clinical psychologists are already working in strained systems where the threshold is so high for entry into the services that by the time people get in, they present with much more long-standing and complex issues that are likely to be beyond the remit of somebody who's kind of briefly trained in providing kind of more straightforward services, and that's part of the issue. Is does the workforce match the need?
Okay, and this need, I mean, I guess we know this. We've had story after story. It's grown hugely over the last, what would you say, couple of decades?
Mental health is a huge issue across the whole New Zealand population, and it's been undercooked and under-resourced and under-scoped for decades, in fact, forever, really.
Unfortunately, yes. Well, we have some information about sort of changes over the last couple of decades, particularly kind of local and matching global increased rates of mental distress that are probably related to a number of factors, including lifestyle, where we're multitasking using digital media, digital technology, and also financial and global kind of crises. We don't actually have, decent information about the actual need for mental health services because that relies on prevalence data. And currently in Aotearoa, the last prevalence study that was done for adults was Te Rauhi Ngaro, and that was well and truly over 20 years ago. So it's definitely out of date.
This lack of data collection, it's a thread running through a lot of our stories, that it's pretty easy to cut a line in the budget by just stop collecting information. Is that what you're experiencing here?
Yes, so I guess, one question is the money going to the right places? And it's hard to tell given the lack of coherent overview of the mental health landscape. Recent Mental Health Commission reports suggest increased access to crisis care and reduced access to specialist mental health services, particularly by young people.
Mental Health Minister Matt Ducey says the feedback he gets is that the system feels fragmented with long wait times, and he wants to change that.
In the last 12 months, an extra 35,000 people access support above the previous 12 months, largely attributed to quite a significant reduction in workforce vacancies. But that was for adults, and young people didn't have the same pickup.
Young people are facing more psychological distress and finding it harder to get specialist help. This is according to a new report.
I'm seeing more and more younger people who are coming in at a younger age with really significant need. And a lot of that is young people who were, in their very formative early years during COVID, when their families were stressed, the country was stressed, we were all divided. And that affects us, that affects how we grow up.
This doesn't suggest that we're providing timely and effective care. And if you think about, calculating what we actually need, over 20 years ago, an exercise was conducted in the mental health system that existed at the time to work out how many services we needed for the population and how much, how much of each type of workforce. That was a document called the Blueprint, and its aspirations were unfortunately never realised, partly because of cost, but also because of planning and changes in government. To actually know what we need, what services we need, and whether we're funding the right services in the right place, we need decent prevalence data. We need to repeat Te Rahi Ngaro, the adult mental health and addiction prevalence study that was last done over 20 years ago, to complete the child and adolescent mental health prevalence study that's been commissioned by the current government, to then taking that information to knowing kind of what look at the services that we have available and redesign the system to meet that need, and then look at the workforce that we need to fill those services and train enough people to actually fill those roles. So prevalence data needs to precede system redesign, which also needs to precede workforce planning. What seems to be happening is things are happening in reverse, with kind of bits and pieces being added to the workforce, the system redesign kind of not really being looked at, and big gaps in prevalence data. And if we keep avoiding this essential work, we'll just end up paying more for less effective care.
Right. Well, in the absence of data, how do we make decisions on what's needed? Is it all based on anecdotal stuff, or who gets in the minister's ear?
Well, it appears piecemeal from our point of view in terms of how decisions are being made. It seems as if it's being made somewhat. These decisions are being made somewhat reactively and in response to lobbying, rather than in a transparent, planned, and equitable manner. And funding for primary services, NGO services, and specialist services should all happen within a whole of system plan, rather than this piecemeal way. And it's not always actually about needing more, but about making sure the money goes to the right places and that they're delivering what is needed.
Sounds like you're talking about the Gumboot Day funding for $24 million that wasn't even asked for.
Health officials had to invoke a special opt-out clause to ensure that the $24 million given to Mike King's Gumboot Friday initiative to make sure that complied with government contract rules. The move is revealed in documents that have been released to RNZ under the Official Information Act. And meanwhile, the chair of the charity behind the initiative says the level of scrutiny it's faced has been devastating, and there seems to be an assumption that the organisation must have done something, quote, dodgy.
A couple of years ago now, but it was pretty notorious.
Yes, it was. And I think that was an example of something that was kind of hard to understand from our perspective. But I guess it's not that it didn't have value and it didn't help people, but I think other providers certainly felt it was inequitable and not fair that, their contracts kind of got stripped and funding got given to other people without a due process.
And now this latest announcement includes $1 million per year to go to NGOs like that to increase support. But, is this just funding that had been previously taken away?
We're unclear about how the proposed NGO funding differs from or builds on the existing mental health and addiction community sector innovation fund, or kind of how it kind of mitigates losses from previous cuts to NGO funding. And we will be asking the Minister for more detail on that. But at the moment, I'm uncertain.
The Royal College was not consulted about this round of funding allocation.
Unfortunately, it doesn't seem as if whole of system planning has been done in a way that includes all the key stakeholders. It seems like there are different conversations happening at different times, leading to funding being allocated in this piecemeal manner within the current constraints of the government's kind of funding envelope.
Let's look at maternal mental health now, because that's had a lot of publicity in the last few years.
The leading cause of death for women who are pregnant or have just given birth is suicide. Our rate is 7 times higher than the UK's, with wahine Māori making up a whopping 57% of all maternal suicides.
$20.18 million for maternal mental health support, and that's including those peer support workers that lived experience that you're talking about, I guess, mums who have been through the same thing, I suppose. Clearly maternal mental health has been an issue. Is this fund going to the right place? Is it well directed?
Well, it's great that there will be kind of increased peer support for maternal mental health services. We know that most maternal health issues arise after the first few days that somebody's given birth, not in the immediate kind of day or two afterwards, and that it can evolve kind of over weeks to months. Maternal mental health services have historically been chronically under-resourced, and so it's been difficult, particularly for women who've been experiencing more serious or complex needs, to access specialist care, and for a very small number to access inpatient treatment through mother and baby settings where they don't lose contact with their child. And so for those groups with greater need, peer support, the peer support funding will not replace what they do need. A different kind of funding is needed for specialist mental health clinicians who are trained in supporting them with talking therapies and medication.
So how does the 3-night hospital stay after birth announcement ease this issue, or does it not?
Budget 26 delivers $34.4 million to strengthen maternity services and to provide more support for mothers and babies in those crucial first days after birth. It also reflects a key commitment in the National New Zealand First Coalition Agreement to ensure that new mothers can access a 3-day postnatal stay.
Well, the 3-night hospital stay is probably useful for a number of reasons in terms of reducing maternal immediate postnatal stress for women, also kind of increasing support for breastfeeding and for bonding, but it won't help to address serious mental health issues, unfortunately, as these arise within days to weeks after birth rather than the first few days.
What is not in the announcement that perhaps disappointed you?
Well, there are many things that are not in the announcement that disappoint us. What we are calling for from the government ahead of the election is some decent workforce planning. So trying to find ways to fund more of the specialist workforce, including psychiatrists, psychologists and others, to be trained to actually meet perceived need, because we don't have accurate figures on need. We're also calling on a whole-of-system approach, so actually for them to do the exercise, to look at the whole system and all the increasing multiplicity of bits that there are within the mental health system, to work out whether they do fit together, whether they are working well together and achieving the goals that they would like, and that we would all like, and that the public deserves, and also to base decision making on evidence rather than lobbying.
Can you talk to me a little bit more about the training of clinical psychologists? Are there loads of people, students lining up wanting to do this and there's no places, or does no one want to do it, or are they all going to Australia when they graduate? What's going on?
So speaking of a non-clinical psychologist, from what I understand, there have been very limited training places available for clinical psychology historically in this country. I think less than 20 a year. That's been increased by the current government, which is great. When you look at need in terms of specialist mental health services, we probably need double or triple that amount, in fact, in reality. As we've had an aging workforce in psychiatry, I believe there's also been an aging workforce in clinical psychology, which means that without boosting the numbers coming in, we're at risk of kind of greater attrition of the existing clinical psychology workforce. And I think that's why the assistant psychologists have been proposed as a solution. But if they can't do the same thing, if they can't meet the same needs, then they won't actually solve the problem that currently exists.
Now, is it difficult, from your point of view, to argue on the specifics of these needs when you don't really have the figures to back things up?
So even though we don't have prevalence data in the community, we do have data on the number of people seeking access. We have some information, not about kind of whole of population need, but about the subset that has tried to seek mental health care, the time they've been waiting, and what's happened to them kind of once they've entered services. So based on that, even based on that limited amount of data, it certainly doesn't appear as if we're meeting demand. We also have perspectives. We have lots of kind of voices from around the country of people who are trying to access services and their families who are speaking out, telling us as clinicians that they're not able to get the care they need. Lots of parents, I think particularly of children and young people with mental health issues, struggle to get their kids seen in a timely manner. They struggle to kind of see their children and young people improve once they do access services, because they may not see the right clinician with the right training in time. And so problems evolve, they become more complex, they become more chronic, and then you end up with the workforce voting with their feet, people leaving public services to work in private services to go overseas, and there being even greater shortages of staff within the specialist mental health system. So it's been a bit of a sort of self-fulfilling prophecy, unfortunately, but it is something that is reversible with proper planning, and that's what we're advocating for.
Have you worked out how many people in the workforce we're short of?
Well, we know from a psychiatry perspective that we have relatively low numbers of psychiatrists, around 13 per 100,000, which is much lower than the kind of OECD average of 18 per 100,000. And I'm not sure for the other specialties, but I'd imagine they're all kind of lower than Australia or similar countries. But the problem with kind of working out how many you need is that you need to know the type of services that you're offering, so what the mental health system should look like. And that's the system design that I'm talking about, because the figures we have got here, or with the system that we have here, would be different from a different type of system that's designed in Australia and in Germany, where things are much more innovation focused. They would have double or triple the number of psychiatrists that we have in this country, because their mental health care is more inpatient focused rather than community focused. So it does depend on the type of system you design as to how many of each type of clinician that you need.
Yeah, it seems, I guess these announcements are great. Look, mothers get this and, other people get this. But it's hard to advocate for backroom roles, and those are exactly the ones that are getting stripped out because of budget cuts. The type of people who plot and plan and work out what we need.
Yes. And I think we talk about frontline clinicians, but we've also seen that, last week we learned that almost 100 frontline health workers may need to apply for their roles as part of a major restructure in central New Zealand hospitals. We're seeing IT staff cut across Health New Zealand, and those have kind of impacts on the remainder of the clinical workforce as well. We haven't seen, as I said, a comprehensive long-term mental health workforce plan from any side of politics. We've seen some movement from the current government, including Minister Ducey, and acknowledge that progress, but the scale of change does mean that more is needed. And we're yet to see detailed mental health commitments from Labour heading into the election, particularly when it comes to their plan for growing the workforce. When they last formed the government, they committed significant funding to mental health, but large portions were slow to roll out or remained unspent because the workforce simply wasn't there to deliver services. And that matters because we know from recent polling that health is the number one priority for voters when it comes to government investment. So there's clear expectation from the public that this is an area where sustained and meaningful action is needed. And from our perspective, it means we do have to move beyond these short-term or piecemeal kind of measures or funding towards consistent long-term planning to build and support the mental health system.
Would there be a similar fear with this $100 million dollop that the money is there in practice, but there aren't enough people to spend it?
Yes, well, that is one of our fears, is that even though the money's been committed, if there's not an adequate workforce to, say, staff the inpatient services, that money won't get spent.
So how would you sum up Matt Ducey's announcement last week?
Well, it's great to have a little bit more. It'd be even more wonderful to see this funding put into the context of a bigger picture, to know that money's being put into the most important place.
That's it for today. The Detail is a newsroom production supported by RNZ and New Zealand On Air. This episode was produced by Gwen McClure and Shalise Tansey and engineered by Phil Benj. Thanks to Dr. Haran Fabru. I'm Alexia Russell. Ka kite anō.